Hi, good morning or good afternoon, wherever you're joining from. My name is Morgan. I am a family nurse practitioner. I'm so excited for you guys to be here today. Any questions while we're kind of just waiting for people to come in? You can go ahead and put them in the chat. I am going to be using Slido today. If you guys aren't familiar with that, we've been using that a lot in a lot of our webinars. So I do ask that if you can get your phones out, and we're going to answer questions and just really try to learn a lot together this morning. So please, please, please feel free, put things in the chat. I'll be trying periodically to kind of look at that. Um, I will try to get back to you. You can also always email questions to us at nursepractitionerarcherreview.com. So if you have any questions after today's lecture, please reach out. If you have any feedback, we like feedback there as well. And just a couple of things that we have some cool offerings. I know we talk about this every week, but it's just really great. If you are studying for your boards, we have the SurePass Pro here. You can go ahead and scan that QR code if you are not already. Take a look at it. It has our on-demand videos, it has our question bank, it has access to tutoring or mentoring to kind of help get an individualized plan if you need that kind of a guidance. We have really, really wonderful tutors that are there to support you. Also, if you've already passed your boards, you're getting ready for something like a job interview and you need a little bit of mentoring, please feel free to reach out and schedule. So we are here. I'm also a mentor tutor and would love to talk through job interviewing or what to look for in a contract. Also, things how to manage certain patients. So, if you're already there and you don't feel like you are getting the support and you have questions that maybe things you didn't quite learn in school, don't feel like you have like the perfect person to ask. We love working with students, so or new nurse practitioners. It's a really, really, really fun thing to do. So please, if you haven't already, scan this, look at what we have on our website. We are offering some really, really cool things. Okay, so I today am going to talk about menopause. I find that, at least in my program, I went to the University of Washington. I think it's a wonderful school. But we have limited things that we get to learn in school. And I think menopause is one of those things that gets a little shorted. And as probably my demographic and what kind of patients I attract, this is something that I'm hearing so many people come and ask me questions on. And I just didn't feel completely prepared to answer their questions. And so I have been working on getting a certification through the North American Menopause Society. They offer that certification twice a year. If you're interested, look it up. It's NAMS is for short, NAMS. But they do offer lots of really great information if this is something you're interested in pursuing or just learning more about so that you can provide care in your practice. All right, we are going to answer questions together today in Slido. So like I said, go ahead and pull out your phones and scan this QR code. And I am going to get it started here. You'll actually be able to scan. I'm going to switch our screen here so we can see our answers. And I'm going to present, sorry, here. I just have to start it so you can all get in. And we're going to just get started with where are you all joining from? So you see this QR code here, you should be able to scan. And this is just like a little practice, but also it's cool to know we have people usually from all over. Um, Let me see if I can do it here. Just make sure it's working. Okay, can you guys see this? Can you type it in? Let me see, is it not working? Join. Mine is going a little bit slow. Are you guys also having problems with it? Oh, yeah. So if you can scan that QR code that you see on your screen. I am in Denver, Colorado. It's a beautiful day here. Results. There we go. Awesome. So Florida, West Virginia, anywhere else? We have some other people joining us this morning. Okay. Oh, somebody's typing. We'll give them a moment. All right. Ram. I'm not getting that. Um, California. Awesome. Okay. Good. All right. So keep this open on your phones. We're going to go through today and we're going to do lots of, yeah, where is Ram? I don't know. That's a good question. S. Man, am I sleepy today? I'm struggling a little bit with these locations. Okay. Next question that I have for you is who do we have in the audience today? Do we have nursing students? Do we have practicing nurses? Do we have NP students? Do we have practicing NPs? Or is others the other one? So yeah, NP student, awesome, wonderful. Practicing NP, great. Okay, some others. I wish I could make it so that you could type. I'm curious who else we have, but this is great. Okay. Well, let's dive right in, you guys. We are going to talk a lot about perimenopause and menopause. So, um, we really just want to understand kind of like overall, um, trying to make you feel a little bit more comfortable with caring for a patient who comes in and is complaining, midlife, maybe 40s, 50s, complaining of things like hot flashes, mood swings, vaginal dryness, dyspareunia, like pain with intercourse, because these things are common and we need to feel comfortable on addressing these. So, our goal today is really just understanding what's happening in women's bodies when they're going through these changes, understanding the symptoms and how to diagnose it. And then what can we do to help people? All right, we're going to go in a little bit. I'm going to talk very briefly on the Women's Health Initiative, which is a study that really has changed the way that we practice, kind of swinging the pendulum from one extreme to the other. Okay. And then at the very end, I do have a case study. Hopefully, we can get through it all. If not, I have a brief summary slide so we can get that part. Just because this does seem to take a little bit longer. I wish we had 90 minutes instead of 60 today, but all right. Just to get started, just a quick overview of the female reproductive organs and our cycle, just to kind of refresh your guys's, review of anatomy before we dive into that kind of how everything changes over the life. So, we have our ovaries, right? So these guys really house thousands of follicles. They play, a central role in conception, respond to releasing mature eggs during our menstrual cycle. We have our fallopian tubes. These guys are the slender kind of conduits for those eggs that are released from the ovaries. Fertilization typically occurs in that fallopian tube when a sperm successfully meets the egg. Then it drops down into the uterus where that egg is going to implant. All right. This is a muscular organ. It grows and sheds on a cyclic pattern, right? In response to different hormones and fertilization. Again, it's going to be where a fetus grows during pregnancy. Cervix is the lower part of the uterus that connects to the vagina. It's kind of the gateway. It allows passage of sperm into the uterus, as well as any sort of blood products passing through during menstruation. Obviously, that's what's going to open to 10 centimeters for us to deliver a baby if we were to be pregnant and go to term. The vagina, this is our birth canal as well. It really is just the passage of sperm during intercourse, serves as the exit for menstrual flow as well. Okay, so another quick Slido here. What hormones, the question that I have for you here is, one second, let's get it up here. What hormones do you associate with the female reproductive system? Anything that you can think of. What hormones do you think of when we're thinking about just the way that the female body kind of goes through its cycles? What kind of things do you know about? FSH, absolutely. So that's coming from our pituitary. Estrogen, yep. So the estrogen's coming mostly from ovaries. Yep, luteinizing hormone as well. Anything else? There's a big one that kind of helps maintain a pregnancy. Progesterone, yep. Some testosterone, absolutely. Women have testosterone in their bodies for sure. Anything else that we think of? Have you ever heard of? Yes, great, progesterone. All right, we're gonna dive into them. But the big players that we think about with our menstrual cycle are going to be um, our estrogen and progesterone, FSH and LH. Okay, these guys all work together. There's a lot of other ones, anti-Müllerian hormone, um, and which also has a big role in our reproductive system. It's something that we'll talk about here. But when we're thinking about the menstrual cycle, let's just focus on these to keep it kind of simple. So, showing the textbook 28-day cycle in a situation where, exogenous hormones are not being used. So, this means nobody's on any sort of contraception, right? This is what we would typically see in a female body going through their cycles. So, some on average, a cycle is about 28 days. Some women experience shorter cycles, others experience longer cycles. And there are many, many different factors that can influence a woman's cycle from month to month. For example, stress, diet, exercise, all of those things are going to play a role into it. Hanging out with other women who are on their cycle, for some reason, we seem to kind of sync up. These things are just biological, they happen. So, with that being said, the female body really is designed to begin ovulation around 10 to 14 years of age, and it stops ovulating around 45 to 55 years of age. All right, so during these fertile years, the female body changes on a monthly basis in response to these different hormones, allowing for reproduction. Like I said, the cycle is typically about 28 days with a follicular phase that's going to last about 14 days, and then the luteal phase that lasts the second 14 days. Early follicular phase FSH levels, we start to see those rise, which initiates a wave of um, egg genesis. Okay, so we start developing some eggs. A dominant follicle is going to be selected, and then estradiol is going to go up very, very exponentially until the mid-cycle peak about day 13. This peak in estradiol is going to initiate the luteinizing hormone and to a lesser extent FSH to kind of surge on day 14. Okay, so that's where we really see this ovulation happen. So that LH surge is going to complete the process of ovulation or the release of the egg, and then that corpus luteum starts to to form, and progesterone production is going to rise dramatically over that second half of our cycle. And then kind of peaking about days 20 to 22. And in the absence of pregnancy, that corpus luteum starts to degenerate, hormone levels are all coming down, and then that uterine lining starts to shed, and then our cycle restarts. Okay. So that's typically how we see it. Here's just another visual that I like to see to help kind of see that 28-day cycle. We have our follicular phase ovulation again, right here around day 14. Okay. And then we're in our luteal phase here, where we're starting to see if pregnancy were to occur, then you would, stay pregnant. But if not, we start back over and we have a menstrual period here. And that's where we're seeing shedding of that uterine lining that was growing. Back here, we can see this is the endometrial lining phases, right? So here we're shedding, shedding, shedding. Starting, and then it starts to grow. And then as that progesterone and estrogen decreases, that's when we're going to start shedding that uterine lining again. Okay, so what do these different things do? We have estrogen, which really is going to stimulate the growth of reproductive organs, right? So those are our secondary sexual characteristics, and it also thickens that endometrial lining. Progesterone maintains endometrial lining for pregnancy, and then FSH and LH are really what are regulating the estrogen and progesterone. So FSH, LH coming from the pituitary to keep those cycles happening. So they're stimulating the ovaries to do its job. Okay. So what symptoms do you think about when you think of perimenopause? We're going to do another quick Slido here. So when you're thinking of perimenopause and menopause, what are you, what symptoms do you associate with this? Okay. Any symptoms at all that you can think of? Right. Hot flashes, absolutely. Vasomotor symptoms. Yep. Anything else? Vaginal dryness, fatigue, yes. We have menopause, perimenopause comes with a lot of symptoms, and we're going to go through all of those. Okay. Oh, let's wait. One more person's going to share last. Sleep interruptions. Absolutely. All of these things are true. It goes beyond just the hot flashes. So we're going to learn about some of the other things that you could see with your patients and kind of know how to just give some anticipatory guidance, right? We give anticipatory guidance to parents all the time when they're raising their kids, but we often don't give women anticipatory guidance about how their body is going to change when they start going through things like menopause. All right. So, if you're really familiar with my lectures, you know I really love epidemiology and statistics. So, here's just a quick slide telling you why does this matter? Okay, so why do we care about this? And if I haven't convinced you already, we have over 90 million women in the United States that are over the age of 50 or will be over the age of 50 by 2060. That means in the next 20 years, we're going to see more and more women entering this perimenopause and menopause state in their life. So we, as their primary care clinicians, better know how to address this. 80% of women report vasomotor symptoms. So that's the hot flashes. And they last on average 7 to 8 years. Okay. So that's kind of a long time to have really significant hot flashes. These can be very disrupting, even for your job, for your performance at work. These things go beyond just that hot feeling. Okay. They have a big psychological impact as well. Um, and we think about 1.5 million visits annually. And then another 50% of people report genitourinary symptoms, GU symptoms. I'm going to say that that number is probably a lot higher, but women are just not accustomed to asking and talking about this. So we as their clinicians need to be comfortable about asking questions in a very sensitive way, but letting women know we don't have to suffer anymore. Okay. If you're experiencing this, let's talk about it. Let's see if we can try some things that might help you out. Okay. So, the role of us as primary care clinicians. So, these symptoms are going to come, they're going to diminish over time, but we do see symptoms as hot flashes, night sweats, vaginal dryness, atrophy, mood changes. Anxiety can be somebody who's never had anxiety may come in and report, I have crazy amounts of anxiety, or I'm feeling this like overall anxious and worried all the time. And this is keeping me up at night. They might just feel like their mood is pretty unstable. They can have just kind of that lability in their mood that just doesn't feel good. Sleep disturbances, lots of insomnia, decreased libido, urinary symptoms, and folks are at risk for an increase or at risk for osteoporosis as they age due to that lack of estrogen. So, we have a few options to really help patients. There are over-the-counter supplements. The North American Menopause Society doesn't recommend things like the black cohosh, evening primrose oil, but some people do use them and they might come to you and then they might find that they're helpful. But they are an unregulated supplement. So not 100% recommended, not great science behind them. If somebody's using it and it's helpful and they don't have any adverse side effects because of it, I'm obviously not going to stop them from doing it. Do I prescribe it? Not typically. The mainstay for menopause is hormone therapy. Some people call it hormone replacement therapy or menopause hormone therapy, MHT. You're going to hear lots of different ways that we refer to this, HRT, HT, MHT, but they're all suggesting the same thing, that we are giving as exogenous hormones, okay? And we can think of these things as either estrogen or progesterone therapy to help relieve the symptoms of menopause, like the hot flashes that we've talked about. We can do hormone therapy orally, transdermally. We have patches, we have gels, we have vaginal suppositories, rings, all sorts of things. It's really just overall important to know that we have these options. And then I'm going to continually say this, if a woman still has a uterus, she can never be prescribed estrogen alone, as it can lead to endometrial hyperplasia. So we want to make sure that we're always prescribing a combined therapy, which would be that estrogen with progesterone in order to really protect her uterus and control the symptoms. Now, that being said, if a woman does not have a uterus, she may still benefit from progesterone. Okay, it's not necessary 100%, but she might still benefit. All right, we also know that some people don't love hormones and they would prefer some other things. So we do have things like fluoxetine or Prozac that can really help with hot flashes. Um, and then this new drug, Xyozah, was approved by the FDA in 2023. So we might be seeing that a little bit more. And there is a lot of research going in. So staying up to date, there are new medications coming out that are non-hormonally based that we can consider if somebody were to have a risk factor that would be a contraindication. All right. Um, Most important thing, we're going to monitor for symptoms. We're going to be doing DEXAs, mammograms, pap smears, colonoscopy, all of their preventative care, right? As we're doing their menopause care, making sure that we're asking about those things, making sure they're up to date on all of that preventative stuff. And then again, normalizing anticipatory guidance around changes. So maybe a woman comes in, she's in her mid 40s, maybe not experiencing any of these things, but it's a good time during their annual wellness visit to have a conversation about some of the changes that she may see happening in her body as she's getting closer to the ovarian function kind of coming down. And then we have to be confident knowing the risks and benefits of MHT. So we're going to talk about that just a little bit here. All right. It's a really, awesome thing that we know how to kind of incorporate this into our practice. So we have reviewed menstrual cycle. Let's talk about what you kind of came here today for and discuss these natural changes that we see during that reproductive system retirement. All right. So as our eggs start kind of doing this, what's happening? So menopause, completely natural, unavoidable. This is a biologic process that's really marking the end of menstruation and fertility in women. Okay. It typically occurs, like we said, in the mid to late 40s, early to mid 50s. And like we said, that average age is right around 51. Overall, over the course of several years, right, our estrogen and our progesterone levels start to decrease, which can lead to a lot of different physiologic and psychological changes. So we have these distinct phases of menopause. So we can break it down into perimenopause, which is just this transition leading up to menopause. This might start as early as the late 30s, but typically in the early 40s, we start seeing these hormone levels start to fluctuate a bit more. So waiting until 50 to start addressing it, it's kind of a little bit late. But we know that in late 30s, mid 40s, most women will start having hormonal fluctuations. The menstrual cycle might become a little bit irregular. We may start having some symptoms of hot flashes, might have some night sweats. I would say definitely mood changes start to occur when we're seeing these big fluctuations in hormones. All right, next stage we have is menopause. And this is where we see estrogen, progesterone levels decline to the point where ovulation no longer is occurring. Okay, so we diagnose menopause after the fact. Okay. Menopause is one day in a woman's life, and it's the day when exactly 365 days have passed without any menstrual bleeding. Okay. After this one day, we then kind of consider postmenopause. And postmenopause is characterized by no more um, no more menstrual cycles, okay? And then those hormones over the course of years will start to level off and normalize. They won't continue these swings. We will get to a point where estradiol levels are low, progesterone levels are low, FSH is going to be elevated. And when we see all of those things start to normalize, that's when the symptoms start to go away. Okay. How long this takes depends on every woman, and it's a little bit different for every single person. Okay, when we think of some of these symptoms, again, we talked about night sweats, vaginal dryness, those mood changes, all of those things are due to a lack of estrogen, oftentimes, and progesterone. Okay, so that's why we're experiencing the symptoms that we're having. All right, we can use the reproductive aging workshop or straw 10 to really understand these different stages. If you're unfamiliar with it, just do a quick Google search of the straw plus 10 to look at those different stages. The North American Menopause Society has done a really nice job of breaking down all of these stages. I talked about the three main ones. They go into a lot more detail to understand that. So if you're really interested in this, go take a look at that. That's called the straw STRAW plus 10 to really look at those different things. So when we think about it, we think about our reproductive phase, right? And that's early, peak, and late. We have menart, which is, the the early stage and usually takes several years to establish that regular cycle. Um, like we said, about every 28 days. And then we have this ability of becoming pregnant, right? Once we have these regular cycles, then we're into our full on fertile stages of life where reproductivity can occur. So we think that over time, as our ovaries have gone through all of the follicles that they have, we start to see less response to the FSH and LH, okay? And that's where we start seeing those mood changes. When we no longer have any follicles in the ovaries, we start to see a decrease in our hormones. And our body is constantly trying. And during that perimenopause area, we may see things like double ovulation in a cycle. We may see anovulatory cycles. They're going to be changing. And this is like we can see the risk of increased twin pregnancies during that perimenopause because the body is trying so hard to reproduce. And we might have these loop cycles where we're actually sending ovulation twice during that point. So contraception in perimenopause is important if a woman desires to not become pregnant and is having intercourse with a man. Then we move into that postmenopause. And like we said, these hormones all level off very nicely. And at this point, women will say that they're no longer cycling and they typically have a very good overall mental health when they reach this point where they say, I no longer have this. So there's some exciting things to come with menopause. Okay, but let's talk about the not so exciting things. So you guys gave really great information on this slide. Thank you for participating in some of the really common symptoms that we think about. But what are some of those other things that we don't necessarily always think about with symptoms? This slide shows you. I starred the most common ones. However, as you can see here, menopause affects our entire body. And I want to tell you that the things that people find really distressing, especially during those early changes of menopause, perimenopause, is these psychological changes, okay? We all are ready for a little bit of weight gain. We're ready for these night sweats, hot flashes. This stuff, we know that vaginal changes occur. All of these things can happen. Our cycles become different. I think that generally speaking, women aren't, they don't know about the psychological impacts. And we think about brain fog, finding words, memory, concentration, mood. All of those things are so important, and this can be very distressing for women. So, I want you to think about if somebody comes into the office reporting some anxiety and some depression and some inability to concentrate, this looks like clinical depression, right? And you may want to jump to an SSRI. And as we saw, Prozac does seem to help a little bit with some of these other things, but ask yourself and have the conversation around menopause. If this is something new, if this woman has never ever in her life experienced these issues and this is just coming on, over the course of the last year or something, and to the point where it's bothering her and she's coming and she's worried, do I have dementia, do I have early dementia, something's going on with my cognitive function. Think about menopause, okay, and have that conversation around it. There might be co-occurring depression, there might be co-occurring anxiety, there might be situational life things happening. We need to get a really good history, but do not just go straight to depression, um, think about menopause, think about these hormonal changes that are happening in her body and have conversations. Typically, if they're having this, they're also experiencing some of these other things. So we can ask about it to help kind of guide our diagnosis as we're coming through. So that moves in. How do we guide or how do we diagnose menopause? It's not straightforward, you guys. It's a bit of a clinical diagnosis. Okay. So we think of their symptoms. We can do blood tests. People love blood tests, but they don't always have a lot of value. Okay. Some people you're going to see, I think there's saliva tests, there's urine tests, there's blood tests, all sorts of different types of tests that we can do. However, if somebody's in a perimenopausal state, their hormone levels can change minute to minute, day to day, hour to hour, okay? Because of where they're at in the cycle, depending on how their ovaries are responding. These ovaries, some days they're doing their job and they're giving you lots of good estrogen and progesterone as they should. And other days, they're just on a hiatus, okay? And so when we get just a one-time snapshot of a serum hormone level, it's not great. But I do encourage people to get a baseline. So we kind of like, can we use any of this information? If she hasn't had a period for over a year and we get this, it will give us a little bit more information. However, if she's still cycling and maybe she doesn't have a uterus, right? It's hard to know where we are in a cycle based on lab testing. That doesn't mean we can't do it. It just means that it's not going to just give us a diagnosis typically. Typically, it's going to give us just some information. We can compare it in the future. Um, but really, what we're asking about is symptoms. And that's what's going to guide our treatment as well. We want to make sure we're not missing anything else. Is there something else going on? And it's nothing to do with menopause. We need to rule those things out. Could she be pregnant? Could she have a pituitary, adrenal, thyroid problem going on? Is there some sort of malignancy occurring? We want to make sure we're ruling these things out. And that's why getting labs can be helpful. And we're going to check other labs, not just hormones when we're doing this. Okay, so we think about blood tests. Like I said, we have limited use, but we need to rule out other causes of those irregular bleedings. So thyroid and pregnancy, stuff like that. So our evaluation. Go ahead, take a snapshot of this. We're going to ask about her gynecologic history, her medical history, nutrition, activity, medications. Is she taking medications? Are she taking them correctly? Are any of these medications have the ability to affect her hormone cycle? What's her family history? Does she know what other women have experienced in their life? We'll get an ROS, socioeconomic status, social history, mental health history, sleep, and making sure we're asking about preventative exam stuff, that mammogram, colonoscopy, pap smears, very, very important. Is she old enough for a DEXA scan? When do we need to start being concerned about bone density, right? And has she ever used menopause hormone therapy in the past? All of those questions, super important. Are you on a contraceptive? Do we need to be on a contraceptive, right? All of these things are really, really, really important. When we do a physical, you can see here, we can, cardiac testing plus or minus, depending on what you know about her history, her family history. And then the labs. So I'm checking CMP, CBC, lipids, A1C, full thyroid panel I like to get just to see what the T3 and T4 are doing in addition to the TSH, seeing if we're having any subclinical symptoms, right, of a hypothyroid. Vitamin D levels, that can cause like a little bit of our low energy fatigue. Is there any sort of anemia happening? And then finally, looking at hormone levels. AMH plus or minus, it tells us a little bit about ovarian reserve, but we want to go through this. And then again, sexual health. We talked about those genitourinary symptoms that women can have, that vaginal dryness, that pain with intercourse, decreased libido. All of those things play a role in our patients' lives. So we want to make sure that we're asking permission to talk about this. Okay, we're gonna go to our next question here on Slido. Um, and then let me just check the chat, see if there's anything. Sorry, nothing in the chat. Okay, so based oops, no, I thought 1 second, did I skip? Okay, well, we went through this. Okay, I just put that in here. Oh, I was going to ask, okay, we're going to talk about the Women's Health Initiative. All right, some of you have heard this. If you're not, I'm briefly going to tell you about the history and the findings of the Women's Health Initiative because it has had a major impact on the way that clinicians and patients approach menopause. And we are not caught up to science, to the evidence yet in practice. I'm curious what you guys are learning in school around this, but just a little bit of background. The WHI was considered is one of the largest and longest running clinical trials focused on women's health in the United States. Okay. They are studying factors that may reduce risks for cardiovascular disease, cancers, hip fractures in postmenopausal women. They have over 160 women enrolled across multiple clinical trials and observational studies. It was first launched back in 1991, and the first results were announced in 2002. And what those results showed was that HRT had more detrimental effects than beneficial effects, and the use of menopause hormone therapy dropped. These negative results of the study received a lot of publicity, a lot of panic. People went off of hormones overnight. Their doctors stopped prescribing hormones because of the results that we saw that these detrimental effects of hormone therapy. And there was a clear message from the media that hormone replacement therapy had more risks than benefits for all women. Okay, that's what we learned about in 2002. In the years following, we did an entire reanalysis of the data. It was reinterpreted. They kind of looked at everything again and looked at both age of the folks that they had and the timing of initiation of hormone therapy in relation to when a woman went through menopause. And the average age of the study participants in these early studies was 63 years old. Okay. Current recommendations tell us to start menopause therapy as soon as possible around the age of 50 or within 10 years of menopause. So if we had an average age of 63 that we're starting menopause therapy on, we have now gone beyond our guidelines. Okay. And this is what we're learning. Okay. So we know that we need to start it sooner and younger. Um, that we would have more benefit than risks. Okay, so the benefits that we see if we do start menopause therapy on younger people is cardiovascular system things. So we reduce things like coronary artery disease. We also are seeing an impact on all cause mortality. Okay, so overall, we're saying like if you start menopause therapy on younger women, it's safer. But if you're starting somebody, over 60 on menopause therapy, we start seeing risks associated with that. So it's not necessarily a good idea to start hormone therapy in a woman who's over 60 or went through menopause more than 10 years ago. All right. The length of time was also a question. So current recommendations tell us we're going to use the lowest effective dose for the shortest amount of time necessary. And then we also think about, well, what hormones did they use? In this study, they were using a different type of progesterone, which is called medroxyprogesterone, which we have decided is not actually good and that may have contributed to the increased risks of cancer associated with these women that we saw in these studies. So current recommendation is actually to use micronized progesterone to really help protect the uterus, that medroxyprogesterone is not sufficient and not recommended for the use. So, just a quick recap. The women's health study was, first of all, studying women that were too old to be started on MHT. They were using the wrong type of progesterone and overall continuing it for too long. Okay. So when we reevaluate all of that information and all of our data now suggests that we actually can safely use menopause hormone therapy, but we are going to see different women needing a little bit different types of um, we have to be considerate of the contraindications and the indications for this. So this, sorry, I wasn't on this slide for you guys, but this is the Women's Health Initiative. Okay, so we can't use just estrogen alone. Okay, and that medroxyprogesterone was actually associated with an increased risk of breast cancer. So we don't use that anymore. We use micronized progesterone, and overall, there's no increased risk of death. With the use of this is what we have seen. So here are risks and our benefits of women treated with estrogen only. This is in the case that they have no uterus. We can consider this. This is estrogen with progesterone. So in the case that a woman has um, both of those things. So we do see a very, very mildly increase in breast cancer. Okay, we have high level of evidence to suggest, but it's not to the point that we say it's not. It's not like a sure shot. If you take this therapy, you will have an invasive breast cancer. That's not what we're saying at all. And in some situations, the risks and the benefits are going to outweigh the risk. But here we can see the benefits. So actually a little bit of a reduction in colorectal cancers, endometrial cancers, lung cancers, no real change, nothing clinically significant here. Diabetes, reduction in diabetes, reduction in osteoporosis, fractures, and overall everything else seems to be, so all cause mortality. What I really want to highlight here, it doesn't increase the risk of death. Okay, and that's what we're talking about here. Urinary incontinence, the evidence here is moderate. Not quite sure if this has this is, this isn't a causal relationship. It's just some sort of association that we see between those things. Okay, so who can we consider giving menopause hormone therapy to? We really need to personalize this. We don't just blanket statement things. We're going to ask about a woman's symptoms, her age, how long has it been since she's had her last period. If it's been more than 10 years, she's typically not a candidate. Her hormones should have at that point kind of leveled off. Okay. We want to ask about health history, and then what are her preferences, right? What is it that she's hoping for? Most patients have done a lot of reading. The decision should, really consider how severe are your symptoms? What are your risk factors for things like breast cancer, osteoporosis, and other conditions based on personal health and also on family health? And if somebody typically decides they want to move forward with it, what NAMS tells us is that we are going to choose women under the age of 60 within 10 years of menopause, and use the lowest effective dose for the shortest amount of time. If they have a history of a cardiovascular event, cancer, DVTs, they are not a good candidate. If they have unexplained vaginal bleeding occurring, we need to figure out what is going on. So here are our relative contraindications. Okay. Sorry, I think I am getting the flu. Give me just 1 second. Okay, do you have any questions about indications versus contraindications here? This is super, super important. If you do, you can put them in the chat. I would be happy to answer those. I'm going to give you a minute. Right. I don't see anybody asking questions, so let's keep on going. So how do we how do we go about prescribing? Um, we have estrogen, progesterone, and testosterone. So estrogen, when we think about prescribing estrogen, we're thinking about those systemic or local symptoms that may happen. It can help reduce osteoporosis and coronary artery risks. We don't prescribe estrogen if somebody is asymptomatic as a prevention at this time. That evidence may shift where we say, okay, we have enough evidence to say that estrogen and progesterone therapy um, are really much a preventative approach to things like osteoporosis, coronary artery disease, but we can't say that right now. So if your patient comes in, she's not having any symptoms of menopause, she's flowing right through it. Um, we are not going to prescribe as a preventative for osteoporosis. Okay. Um, Really important if a woman has a uterus, I'm going to keep telling you this. If a woman has a uterus, we always, always, always need to prescribe micronized progestin. This is an oral capsule that she would take every night. I start at 100 milligrams. We'll talk about that in just a second. What does the progesterone do? It protects the uterus from overgrowing. So, unopposed estrogen will cause that uterus to continue to grow and grow and grow and thicken and thicken and thicken, increasing the risk for uterine cancer. Okay, so that's why we need to have estrogen that is opposed by progesterone to help maintain that uterine lining. Okay, it can help a lot with insomnia. So this is the case where maybe you have a patient who's had a hysterectomy. However, she's experiencing a lot of insomnia, that anxiety, all of these different things that could be occurring. You can start with the estrogen patch and see how that goes. And then if still having, some relief, but not all the relief, go ahead and add on that progesterone. But we don't need to necessarily jump off with both of them right at the start, depending on what you think and the clinical symptoms and what you discuss with your patient. Oftentimes, like I said, women kind of are doing this research on their own. They're coming to you with kind of a plan, and you just need to be ready to answer yes or no what you think. All right, testosterone. This is huge in the news, huge in social media. We do not have FDA approval for prescribing testosterone in women. Does it make a difference? Yes. Australia, they do have approval, and they are prescribing with their equivalent of FDA approval with postmenopausal women. And what we see is when we use estrogen, just or testosterone, just like when we use it in men, it alleviates a lot of those same symptoms. So men come to you with a low testosterone level, and they have brain fog, they have low libido or decreased sex drive. They feel like they just can't get through a workout, or that they're losing their muscle mass. They might be a little bit more, just kind of emotional and don't feel like themselves, fatigued, just that low energy. Women can have the same thing. What we're realizing, NAMS is kind of on the border here where they're not giving great recommendations around testosterone quite yet. I think they're waiting for more evidence to come out. But as we're seeing this, women are taking testosterone off label right now, every single day, with a benefit in some of these symptom improvements. Okay, so just be aware when people come to you, what is your stance on testosterone? You can read the literature, figure out where you fall on it, and maybe have a personalized conversation with a patient and see, is this something that you feel comfortable with? Do they have risk factors that would make you uncomfortable with using it? And make your decisions kind of very much on a personal basis. Okay, so clinical use of estrogens. So I think of dyspareunia a lot. This is a condition that causes pain during sexual intercourse. It can occur, before or after or during intercourse, and it's really associated with vaginal atrophy or atrophic vaginitis, which is just that thinning, drying, and kind of inflammation of our vaginal walls. This just might occur as our body is aging, when our body has less estrogen, that the tissue just starts to kind of atrophy a little bit. So we can go ahead, if that's our only symptom, or if somebody is experiencing a lot of UTIs, all of these things we could consider. Maybe we just need something local. Maybe we just need to really address the symptoms of what's happening in the genitourinary tracts. And that would be something like a topical or vaginal cream or ring that we can place. And we see very little systemic absorption of those. So we don't have the increased risk of like DVTs or clots if we're worried about it. And this is really going to help address some of that atrophy. I tell my patients it just kind of keeps a little bit of a youthful vagina so that we can have decent moisture and not have pain, and kind of keep things kind of plump in the way that they look. Okay. Um, if we do, sorry. if we're doing just localized, we don't necessarily need that progesterone. If we're only using localized estrogen, then we don't, and we don't have any other symptoms, we're not necessarily needing to use that progesterone for uterine protection because it's very much a localized ish effect, and it's just really in the vagina. Doesn't seem to cause that hyperplasia in the uterus. All right. However, if we're doing systemic things because we have systemic symptoms, so we're hot flashing, we have mood swings, we have all of those things, my go-to is going to be a transdermal patch. I start at the lowest dose and we increase about every month depending on how she's doing, and we're going to use that lowest dose. There is also oral estrogen. However, we think of a little bit of an increased risk of DVTs. This is a very, very low dose. However, if we can avoid that first pass effect through the liver with the transdermal, and these are affordable and they're easy, you just put a patch on, keep it on at least some of them are weekly, there are semi-weekly, so you'll switch it in the middle of the week. And then there's also gels that women do like that they just rub on topically. All right, the message here, start low, go slow. We're going to titrate to the lowest effective dose to maintain and manage symptoms. Okay, or decrease and manage their symptoms. Okay, so next up, progesterone. Progesterone necessary for those with an intact uterus if we're using systemic estrogens. Okay, always, always, always. So our indication again is that uterine protection, but we also see some improvements in things like hot flashes, night sweats, anxiety, and insomnia. Like I said, if she's had a hysterectomy, she doesn't need progesterone for the uterus any longer. However, would it benefit her in these other symptoms that she may be experiencing? The way I would start that is go ahead and start with my estrogen and then consider adding this on. Typically, we do a daily dose, or some people like to do a cyclic dose to kind of mimic that system. So when we do a daily dose, it's 100 milligrams. I always tell them to take this at night because it can cause you to feel a little bit tired. But the cyclic dose, we're going to increase the dose to 200 milligrams and we're going to take it um, through the last half of the month, okay? Starting on day 12 or 14, and then for 2 weeks, just to kind of follow those the cycles. Okay, and then we talked a little bit just about this testosterone. Again, this is just completely based on your personal preference. We don't have a lot of guidance around this. We are looking, there are injectable forms of testosterone that women are using. There's pellet forms of testosterone that women are using, and there's topical. If, conservative approach would be a topical 1 to 2 milligrams daily. You apply it to a fatty area, rotate your sites. I say just do it after a shower to help absorb it. But when we put in things like a pellet, we can't take it out. Our biggest concerns around testosterone use is going to be masculinizing effects, right? So we're gonna definitely have these conversations with women. Is there hair growth occurring in places that is new? Are you losing hair? Is your voice deepening? We would have to get to pretty high levels, but with things like pellets and injections, I would be a little bit more concerned of getting those adverse masculizing effects if that's not what they're going for, if that's not what she wants. She just is hoping for a little bit of energy and maybe improve her libido and muscle mass, make her workouts feel more effective. Then I would say a topical is just a very conservative place to start. The other, like I said, this is completely off FDA off-label use of testosterone. We have these non-hormonal options that I mentioned earlier, supplements. We don't have recommendation by North American Menopause Society to use those. However, if your patient finds that they're helping, I wouldn't say they needed to stop unless I were seeing an adverse effect from those. We do see some role of SSRIs. This used to be kind of a first-line treatment. I urge you to really have conversations with your patients and go beyond the SSRI conversation to talk about whether something like some hormone therapy may be helpful in addressing concerns or changes in her mood. Okay, if depression and anxiety just seem kind of like newish in her lifetime around menopausal age, like I said, just have a conversation about it. This can always be added or taken away if you decide to add something like an SSRI. All right. Again, lowest effective dose. Really important. I'm going to go over these very briefly because I have a case today I want to talk about. Mammograms. Every single year, we want to be getting mammograms if somebody's on HRT or MHT because we want to make sure that we're really, really screening closely for this. I always say get a mammogram, potentially a uterine ultrasound before starting to make sure there's nothing that's going on in that area. Continue. Cervical cancer screening guidelines don't change because of therapy. We want to make sure that we're screening people for cervical cancer. These are our follow-ups, right, that we might see. And then referring to gyne if we have abnormals. Okay, now let's jump in. We have 7 minutes. We're not going to get through all of this case study. I am so sorry. But let's just jump in and talk through it. So pull out your phones again and let me pull it up here. We are going for our first thing. Okay, so our case study question here is okay, we have a patient, 51-year-old Maria. She's a cisgender female. History of hypertension, well controlled with lisinopril, otherwise healthy, blood pressure, heart rate, vital signs 100% stable. Has a family history of diabetes. Somebody died of a heart attack potentially. And she says that she's had irregular menstrual cycles for like maybe about a year. They're short, but they feel like they're coming more frequently. Hot flashes, night sweats, trouble sleeping, some vaginal dryness, a little bit of pain, decreased libido. Sorry, I don't know what the L is there. Oh, LMP, 7 months ago. So her last menstrual period was 7 months ago. No history of a hysterectomy, or she's not on any hormone therapy, non-smoker, and exercises regularly. I'm going to add into this. She is sexually active with a male partner who has had a vasectomy, so contraception not a concern. Okay, her physical exam findings, EHNT is normal, cardiovascular is normal, abdomen is normal, pelvic exam. We see a little bit of early atrophic vaginal vaginitis, no masses, no lesions, everything looks good. Let's say her pap smear came back normal, she was due, you got it, everything looks good there. And you ordered some labs. And here are her lab findings. We have FSH at 38, estradiol at 15, TSH 2.1, prolactin at 8.5. What I'm going to tell you is that the FSH is high, estradiol is low, TSH is normal, prolactin is normal. Okay, so based on this, what is her most likely diagnosis? What do you think is going on here? And how would you classify this? And if you're not on, you guys, you can take out your phones and just scan this QR code and it'll pop right up. Just click join and you can go ahead and participate. This is how we learn. I love all the answers here. Yeah, perimenopause, menopause. Absolutely. So, next question that we're going to go to here is what are, oops, okay, that question came out of order. Okay, how do you differentiate between perimenopause and menopause? Any ideas? What are the differences that we see between perimenopause and menopause? Do you remember how what kind of definitions we gave? Yep, exactly. 12 months. It's one day in your life that you're reached menopause, 365 days, hormone levels, age, symptoms. Yep, great. Um, just wanted to show you this slide really quickly. So we diagnosed her with menopause. She's 51 years old, which is typical. She hasn't had a menstrual period in 7 months. So technically she hasn't hit that 12 months of amenorrhea, but she does have our classic vasomotor symptoms, genital urinary symptoms, and we also see her hormones are showing us, even though we haven't hit that 12 months, she likely chance she's not going to have any more periods because of her labs that we're seeing here. Okay. This FSH, once it's getting up and estradiol is going down, we're probably pretty certain that that ovarian function is done. The ovaries aren't really doing anything anymore. All right, so how do we differentiate? Just like you said, that 12 months, that's kind of it. And then consistently high FSH. So you would probably need more than one lab to diagnose this, but we're going to go on symptoms. We're not going to have her do blood draws after blood draws and spend a bunch of money on these labs. We're going to assume she's somewhere in between these two. And we're probably at that point where I think it's been 7 months. Seeing those initial labs, I'm guessing we're not going to have any more periods. We can go ahead and have a conversation, but even during this area, we can have a conversation about hormone therapy if that's what she's hopeful about. Okay, what additional symptoms could present with similar findings and how do we rule them out? So, what else could be happening? What is on our differential? We don't want to jump straight to that. What other things should have you checked along with her hormone levels? Any ideas? What is something else that could be happening? Yes, thyroid problems. Absolutely. Anything in the pituitary that you can think of? Have you guys ever heard of pituitary adenomas that can increase a little bit of your prolactin? Oh, okay. Somebody asked, I'm just going to answer this live. Lab values, as far as like having things memorized, they're going to give you the normal range. You need to know how to, when you're taking a test, you need to know how to interpret them. So typically on like any of your board exams, if you are taking, any sort of a lab value, they're going to give you your reference range and they're going to ask you kind of to apply that information. Okay, so you don't have to necessarily memorize everything, but know what does the high TSH mean. All right. LH will be high. Oh, your chat's disabled. I'm sorry. Okay. Yes, good. Thanks for getting in there. I'm not sure why the chat's disabled. Um, the Q&A, you can ask in the Q&A if you want to. Okay. Um, let me just pull this back. Oh, you use an iPad. Okay. Sorry. Um, All right, so our next question here is what does I just wanted to show you guys one thing here. Okay. So some of the things that we're going to think about here is that hypothyroid dysfunction, right? So we did check the TSH. The hyperprolactinoma or pituitary adenoma can cause prolactin to go up, which could suppress our menstrual cycle. And then pregnancy, we want to make sure she's not pregnant. So always, you know, women are going to be like, "Oh, that's crazy." But when you're getting blood tests or getting a urine test, I would just add it on, just as a didn't miss it. Okay, we never want to miss a pregnancy, especially when somebody is going through these different changes in their life. Okay, so the levels we talked about, I'm going to ask this question: the levels of estradiol and menopause and the TSH, what we're thinking here. So, like we said, that FSH is going to go up, and that really confirms our variant failure. With an FSH above 30 and an estradiol below 18, we're saying that the ovaries really aren't doing too much. And they really rise to that lack of negative feedback. So the ovaries will give that negative feedback loop. So as the ovaries produce estrogen, then FSH is going to come down. It's that negative feedback, just like our thyroid has with the pituitary gland as well. But if the ovaries are getting this message from the pituitary, stimulate, 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 however, they don't have any eggs left in them. There's no estrogen being produced because we don't have any eggs left. That pituitary is going to keep sending a signal, keep trying to make those ovaries do their job. They just are saying, "Hey, I'm out of service. I'm done. There's no more eggs to be ovulated here." So, you can knock on my door all you want, FSH, but I can't respond. There is just simply nothing inside to do it anymore. Okay, TSH testing, we talked a little bit about that. They can have similar symptoms to menopause. So just making sure we're not like diagnosing somebody with menopause when in fact they actually have a thyroid that's not functioning. But in this patient's case, everything was very normal. I like the full thyroid panel, like I said, just to make sure there's no subclinical things going on, especially if there's like something weight gain or something like that. Go ahead. Additional tests. This is what I would consider maybe that AMH to evaluate for premature ovarian failure. So if she were less than 45, I would go ahead and add that on. And then if there's abnormal uterine bleeding, considering that endometrial biopsy ultrasound for further testing or hormone testing. Okay. So some other things we would do. Okay. First line treatments. We're going to answer this just all at once because we are over our time. I'm going to let you guys go. So first line treatments, recommended treatments for vaginal atrophic vaginitis, lifestyles, um, modifications that we should be doing, and then recommended recommendations and tests. So just kind of overall first line treatment. If it's mild symptoms, we can try lifestyle modifications, layered clothing, staying in a cool environment, keeping the sleeping area cold, avoiding triggers like caffeine, alcohol. Some people say low carb diet can kind of help with this a little bit. But if we're at moderate to severe symptoms, the first line treatment is going to be menopausal hormone therapy if she doesn't have any contraindications. If we can't use hormones, then we have these other things like the SSRIs, SNRIs, gabapentin, and clonidine. These are second line. Okay. Their first line if she's contraindicated to hormone therapy, but hormone therapy is our most effective treatment. Okay. And then just a quick overview. So we have us just jumping right into our summary here. So 12 months of amenorrhea with an elevated FSH and low estradiol helps us confirm those things. We rule out other things that are going on. Um, and our first line therapy would be more hormone therapy. So we could consider, I would go for a systemic estrogen, probably a patch with progesterone. She still has a uterus. So I would do a 0.025 milligram patch once a week and 100 milligrams of progestin, micronized progestin every night before bed. Um, if you're interested in testosterone, she did say she had a low libido. Maybe we could talk about that. Maybe we could consider adding vaginal estrogen if we don't see any improvement with systemic. But because she is having systemic symptoms of menopause, I'm going to do a systemic treatment with that. Um, we'll see how she does, of her low mood and all of that stuff. See how she improves with just the addition. If not, we can have a conversation about SSRIs. If she were to have a history of breast cancer, we could talk about those non-hormone therapy options, right? To see if we can help improve some of those things. Well, like we said, that vaginal atrophy estrogen therapy, the systemic might be helpful. It might not be enough. We may need to add something local to the vagina as well. Long-term health, we are talking always, always, always weight-bearing activity, cardiovascular, risk reduction. We want to think about doing some cardio and weight-bearing activities, physical activity, calcium and vitamin D supplementation. Really, all of those lifestyle changes, super, super important as we move forward. Okay, I'm sorry we didn't get to go through all of these questions. But overall, I like to just finish um, with this question about anything that you guys want to see more of in our free weekly webinars. Is there any, I just like to give everybody an opportunity to give us some feedback, some input as we move forward. I know antibiotics came up last week, so we added that to our queue. Test prep questions with each topic. Okay. So just like, are you talking kind of that rapid 30? Have you participated with us on that rapid 30? Do you guys have any other questions that you're hopeful to get? And any feedback for today, please let us know. Okay. Cardiac meds, hypertension. All right. We are hitting a pharmacology thing really, really hard, really good. Thanks, guys. I hope you just feel a little bit more confident. I know this is not to like get you ready to go out and prescribe, but at least hopefully it opens the door a little bit to what that just the concept of what's happening in our bodies and getting those prescriptions down and feeling confident in helping. Pull up to date if you can, take a look at how to prescribe those things, review your contraindications, have those really, really, really good in your brain. Um, and have this conversation with women. They are very much wanting these conversations. So it's been a pleasure, everyone. Have a wonderful rest of your day. Endocrine system, cardiac meds, yes. Okay. And like I said, we are working with Archer on pharmacology stuff. So we'll be hopefully getting more of those webinars. I did a pharmacology webinar last week. All that stuff is available on our Facebook page. So if you want to go back and watch old webinars, they are available there. So join us here. I'll give you a link here. Um, join our community on Facebook, Instagram, and that way you can kind of get some of this additional information, ask each other questions, and really grow our community of nurses, nurse practitioners, students, and nurse practitioners. All right, it was a pleasure. I'll see you all in March. Have a wonderful rest of your day, and hopefully, good luck on your exams or wherever you're at in your process. All right, take care, guys.